So Proposition 46 has a few different parts to it, and I'm going to talk about sort of what I see as the three main provisions of Proposition 46. First, it would raise the existing cap on non-economic damages that can be awarded in medical malpractice cases. So currently there is in medical malpractice cases, and a person who is injured during the course of healthcare treatment can sue a healthcare provider, and they can sue for damages, and often the damages are one of two types. First, there could be economic damages, which is such things as loss of income, healthcare costs associated with that injury, and then there's non-economic damages, which is oftentimes characterizes pain and suffering. So an injured individual can be awarded compensation for that pain and suffering. There is a $250,000 cap that currently exists on the damages that can be awarded for non-economic damages, such as pain and suffering in medical malpractice lawsuits. That cap was established by the legislature in 1975 as part of a law known as MICRA. It was not indexed to inflation when it was established, so it has stayed at $250,000 since 1975. What this measure would do would adjust that $250,000 cap for inflation, so it would sort of grow it over the past 40 years or so. So that would bring the cap, if the measure were to pass, to approximately $1.1 million on non-economic damages, if proposition were to pass. The second major provision is a requirement that providers, mostly doctors and pharmacists, check a prescription drug database prior to prescribing certain prescription drugs, certain drugs that are categorized as potential high risk for abuse, such as Vicodin or Oxycontin. Now, there's currently a database that exists where if a pharmacist dispenses one of these types of drugs, that information is put into the database, and healthcare providers have the option to check this database prior to prescribing these types of prescriptions to patients or dispensing these prescriptions, but use of the system is voluntary. Now, under this measure, it would require pharmacists and doctors to check the database prior to prescribing these types of prescriptions to patients for the first time. So it would make it mandatory checking of the system. And the third major provision would require hospitals to conduct drug and alcohol testing on doctors that are affiliated with the hospital. So that includes doctors that either work at the hospital, that contract with the hospital, that have admitting privileges to the hospital. And the tests would be conducted randomly. They would be required to conduct tests after an adverse event. So things like if there was a mistake made in surgery or some other type of mistake, then the hospital would be required to test the doctors for drug and alcohol. And if there is a report, if someone reported, say another doctor reported that they thought a doctor was using drugs or alcohol while on duty, then the hospital will be required to test them in that instance as well. So the fiscal effects associated with this measure are highly uncertain on all of these pieces. But first I'll go through what we estimated the fiscal effects associated with raising the cap on non-economic damages in malpractice cases. Generally, it would have sort of two effects on healthcare costs. First would be just sort of the more direct effect associated with higher medical malpractice costs for doctors. So they would be making higher payments for certain medical malpractice claims. Their medical malpractice insurance premiums would likely increase, so there's sort of that direct healthcare cost. It would also result in some change in the amount and types of healthcare services. So in other words, healthcare providers would likely alter, maybe just slightly, sort of the way they practice medicine in response to this sort of perceived increased medical malpractice liability that they have. So for example, that could result in a doctor ordering an additional test or procedure that maybe they otherwise would not have ordered. In some cases, that could save money by preventing a future illness. In some cases, that could simply increase costs because it would just be additional test or procedure without any sort of offsetting savings. So in total, we estimated that these fiscal effects, that overall healthcare costs would likely increase by a fraction of a percent or maybe a little bit more than a percent as a result of raising the cap on medical malpractice damages. So it's small in percentage terms, but moving on to sort of impacts on state and local governments. State and local governments spend tens of billions of dollars annually on healthcare services, health coverage for employees, their families, retirees, the state Medi-Cal program, which provides coverage to roughly 10 million Californians. So even a very small percentage change, even a fraction of a percentage change, can have a significant effect on state and local government healthcare costs. And we estimated that range would be tens of millions of dollars, potentially reaching up to several $100 million annually. Now these costs, we estimated, would be offset to some extent by the other provisions that I mentioned, checking the prescription drug database, testing of doctors. So those savings associated with those provisions would likely offset to some extent the increased costs associated with raising the cap on medical malpractice damages.
Okay, so if this will work. Okay, sorry. All right, so again, lopsided spending. There's a lot of money against this, and most of it is, the second one, the doctors company, is a medical malpractice organization, right? So it's the insurers who insure the doctors, for the most part, who are putting the money in against this. Also, Kaiser Permanente, which does comprehensive health insurance coverage. And then on the for side, we have attorneys, organizations who presumably would benefit from the additional, the cap being raised so that they could potentially get higher settlements in malpractice suits. The endorsements, the Democratic Party is neutral on this one. The Republican Party against, the Libertarian and Peace and Freedom parties all against. Sorry, this isn't working very well. There we go. The other organizations, we have the American Academy of Pediatrics, the American Nurses Association against, Bay Area Council, Chamber of Commerce, Farm Bureau against. Most organizations are against, except for the Friends, which is the Quakers, who are for. The unions are neutral. Newspapers, no. Okay, if we have questions on Prop 46, if you could get to a microphone, please. Or if a microphone could get to you, one way or the other.
So a lot of us get information from television, movies, and it used to be that whenever there was a malpractice case, they would award a dollar amount and then they would award pain and suffering. And am I to understand in California that pain and suffering was always limited at $250,000?
Since 1975.
Okay. Okay, then the other thing was the drug thing. Okay, so now doctors will be required to consult the database to make sure that a doctor isn't just giving out Oxy like they do in Florida. And anyway, so that's the brunt of that.
I think that's one sort of intention, I think, of the proponents, and I certainly don't want to speak on their behalf, but yes, to sort of attempt to address the issue of individuals who are doctor shopping, going to a bunch of different doctors to try to obtain multiple prescriptions for the same thing with the purpose of abusing those drugs. So this would sort of require doctors to check the database before they prescribe certain types of prescriptions to a patient for the first time. And if they see that an individual has an existing prescription for that same drug, then they have to determine that there's a legitimate need for another one.
So the pain and suffering thing, wasn't that designed to be a motivation to discourage and encourage better practices by doctors? And was that kind of a punishment that was meant that has been limited to 250,000?
The medical malpractice system generally, I think, part of its intention is to sort of encourage doctors to practice medicine more carefully. So yeah, I think generally that's sort of the purpose of the system, and then how you sort of adjust the incentives and the amount of damages that can be awarded in medical malpractice cases can sort of affect the incentives for different people in the system.
I should mention that this is only the pain and suffering piece. It's not the medical costs. The medical costs don't have a cap. Other questions?
Does anything in this proposition change the criteria under which a plaintiff can bring a lawsuit? In other words, just because they don't have a desirable medical outcome, does that give them right to bring a lawsuit without cause?
No, it's focused on just sort of the damages award, the cap for non-economic damages, not sort of the cause for bringing a lawsuit.
I just have a quick question. Is there any data that suggests that there are a lot of medical errors being made on the basis of drug and alcohol abuse by medical providers?
There's some information. Again, sort of the quality of the evidence is a little bit mixed, but yes, there's certainly some evidence that some doctors have drug and alcohol abuse issues, but the sort of state of the literature is not entirely complete on that issue.
I have a question on the database. Does this thing, can you hear me?
You get a little closer to the mic.
Oh, I'll get a little closer. Okay. The question on the database, is this an existing database or is it to be built? And why would you want to do this when the major HMOs already have databases that manage the drugs that are being dispensed to the people in those systems? And who would manage this database, and how do you deal with the HIPAA compliance at the HMOs, and then the data comes over to this nebulous thingy, which is, I guess, what we can call it now, and the HIPAA issues? I think, is there anything that keeps it from turning into a big mess?
Those are some very detailed questions. I'll try to sort of answer some of them at a high level, and maybe we can talk afterwards. So I think one of the reasons for having them check this database is that sort of it would exist for all prescriptions sort of across different types of health plans. So a doctor who logs into the system would be able to see if someone received a prescription from a doctor who was maybe not part of that health plan, but somewhere outside of that health plan. As far as the database, the database currently exists. It's called sort of the Cures database, and it's run by the Department of Justice. It is currently undergoing some upgrades, and those upgrades are scheduled to be complete in 2015. The reason why it's undergoing some upgrades is, and I didn't have time to sort of mention this in my presentation, but there is a law that has been passed that beginning in January of 2016, healthcare providers will be required to register for the database. So right now, they're not required to even sort of, register to have access to the database, but beginning in January 2016, they will be required to at least register so they can sort of have their name in the system and they can log in at some point if they choose to. And so they're sort of trying to upgrade the system in order to accommodate some of the increased use that they would expect from that requirement. But under current law, while they would be required to register for the system, they wouldn't necessarily be required to check it each time they prescribe something to a new patient.
Great. I should mention that we do have ads on both of these initiatives, 45 and 46, if you want to check those out another question in the back?
This is good. Yeah, you had said that this testing would be done randomly. Could you clarify that again?
It's a little difficult to clarify because, I mean, it says randomly, and some discretion is left up to state agencies who have sort of responsibility for issuing regulations on sort of exactly what that means. For example, sort of how often random tests would have to be conducted.
So every
a little
doctor
hard.
is not going to go through a testing?
Excuse me?
Every doctor is not going to be tested?
Every doctor. Doctors who are, again, sort of affiliated with the hospital. In other words, they work for the hospital, they contract with the hospital, or they have admitting privileges to the hospital, would, I believe, under the measure, be subject to some form of random drug testing. It's hard to say how often that random drug testing would occur.
I'd just like to comment from the booklet that I'm reading. It says certain physicians for alcohol and drugs. That would generally mean for cause. I didn't see anything that says random. The other thing that I wanted to point out is on the pro, it's saying that estimates show 18% of healthcare professionals have an abuse problem in their lifetimes. That's like almost 1/5 of health. That's a lot. And then it says medical negligence is this country's 3rd largest cause of death. Who prepared this? This is like enormous statistics here.
That's on.
This is on the booklet that I'm reading.
Yeah,
That's not anything that we wrote, I don't believe. So.
no, that's the pro and con that's written by the proponents.
So are
I
these
can clarify-
statistics verifiable?
Some of them are misleading. So I know some of this because we did an ad watch on that. So the 18% number comes from general numbers for the population of the United States. It's not specific to healthcare providers.
That's not what it says here, though.
I know.
Okay.
And it is also for a lifetime. So, 18% of Americans at some point in their lives might have a problem with drugs or alcohol. That doesn't say anything about during the time that a person is practicing medicine or for doctors in particular.
And is medical negligence the 3rd largest cause of death in our country?
I haven't verified those statistics, but that sounds unlikely.
So in order to get in this booklet, they don't have to be factual. Is that accurate?
They can be omitting or misleading. That's why we have things like this.